So it's a great pleasure to introduce my dear friend, Dr. Fernando Rojas-Viscaya, prosthodontist. He runs the Mediterranean Prosthodontic Institute in Castellón, Spain. He was trained at University of North Carolina in prosthodontics. He's also had training as an oral surgeon, so he's both surgical and prosthetically trained. So hopefully in better days, we can all visit his institute by the Mediterranean Sea and take his live classes. But in the meantime, this is a great way for all of us to connect with him and learn from his knowledge, experience, and expertise of clinical prosthodontics. So Fernando, the floor is all yours.
Okay, my dear friend Homer, that is my brother, we are living so far. Okay, I probably think that many of you are surgeon or periodontists, and I want to focus in treatment planning, because at the end what we are doing is placing teeth. All the treatment that we made is at the end to restore with teeth our patient. And for years working in this, I conclude that we need to integrate some aspect when we are working with dental implant. And this is about my presentation and about treatment planning. But basically, when when you are planning to restore a case, we have two options: patient without teeth or patient with terminal dentition, right? And in both cases, we need to, before place any implant, before do any graft, before do anything, we need to restore the case with interim prosthesis. But this means that we need to determine where will be the final teeth in relation with the face of the patient. So when I start planning cases, my first goal is to check how will be the smile of the patient. And the last will be checking for the position of the bone, because with or without bone, we need this teeth. So when I start planning for the smile of the patient, basically, I want to set the teeth that the maxillary incisal curve runs parallel to the lower lip. And if it's in a man, is parallel but not touching the lower lip. And if it's in a lady, it's parallel but touching a little bit the lower lip. So basically here, what I am doing in this patient, edentulous or with terminal dentition, when I start planning, is looking for what is the correct apical coronal position of the new teeth, right? To produce the smile in a frontal view. But also in a lateral view, we need to find the position of the teeth anteroposteriorly to provide the correct lip support also for the patient. So we can move the lip a little bit anteriorly with the position of the teeth, or we can go a little bit posteriorly with the anteroposterior position of the teeth. So basically two things. One, in the determination of the position of the teeth, that is the first aspect in the treatment plan, is find where is the apical coronal position of the teeth that produce the smile, and where is the anteroposterior position of the teeth that produce the lip support. So now you have the case. Now at least you know how looks the patient. You can show a picture to the patient and say, take a look. This is how you will finish after I make everything. So this is the first step. Find the 3D position of the new teeth in the edentulous space or in the potential area to place implant. But how I know where will be this teeth? And why it's important? Because the teeth will be the guide to determine what I need to do with the sinus, with the graft, with the alveolar bone, if I need to add bone, or maybe I need to cut bone, or maybe I need to put pink prosthetic area. So before we start doing anything, we will use to determine the position of the teeth facial lines that we will mix with some points intraorally that remain stable. So when we lose all teeth, some point remain stable. And also we have some average measurements that we can apply in our patient and mix with the external information, with the internal point of reference, and with the dynamics of the lips, how the patient speak, smile. So you can work in the determination of the position of these teeth. This is just an overview. We will check for the extraoral information on the face of the patient, all these lines, and we will mix with the point of reference internally, intraorally, that remain stable. Once using this point, we determine what is the new teeth. So we need to fix in the treatment plan, in a complete denture or in a wax up or in a template. But I need to determine in the space where is this new teeth, because produce the correct smile for the patient, and make the analysis between the margin of each plant crown to the level of the existing bone. And when I make this analysis, I will know what happened. Now it's important the bone, but because now I have the teeth. And we can offer to the patient 3 different types of prosthesis. Imagine that this prosthesis that you can see in the right side of the screen is for the same patient, but at different time in the life of the patient. Imagine that the patient, because an accident, lose all the teeth, and we place implant to restore these teeth. When you make the analysis, probably patient is with a lot of bone, and we need to restore what is the incisal edge that produce the smile of the patient. Probably is the prosthesis in the bottom. If we skip to place the implant and the patient come like 10 years later, the incisal edge and the 3D position of the teeth will be the same to give the same smile, the same support. But now what changed is the bone. So I need to add pink prosthetic area. Or if I wait for 40 years or more, when the patient comes and I make the analysis, my first step is again find the same incisal edge, same occlusal plane, same anterior-posterior position to provide the same support. But now what changed is he or she lose more bone. Now we need to add acrylic to create the proper lip support. But the teeth need to be in the same position, in the edentulous area. This is the point that we use. We have more, but this is basically how I am doing all my cases. So extraoral, we use the line, bipupillary line, commissural line, the midline, and using this line as reference. Intraorally, we use some point, the distal portion of the incisive papilla, the mucolabial reflection in the maxilla and in the mandible, and also the retromolar path. With these points, I will show you how I can use to determine the position of the teeth. Once I know what is the teeth, some part of my prosthesis are important. Probably at the beginning, my prosthesis is not beautiful, but I need to know exactly what is the incisal edge, what is the midline, what is the tip of the canine, and what is the margin of each plant crown, because the margin will be the point of reference to do the case. For the prosthodontist, for the surgeon, will be like the guide, the point of reference, the margin of each plant crown. So this is very important, determine where is each crown to make this analysis. Once we have this margin, we will check the distance between margin to the bone, and we can offer to our patient the different type of prosthesis according where is the bone from this margin. But we have too many ways to do the same, right? To restore a case, you can do the analog way. This is how I start. Just taking impression, alginate impression, pouring cast, duplicate, wax up by hand, or we can mix the analog with some digital part, right? Or we can use photography to make the analysis. Or we can do everything digital, but this is, let's say, the future. But basically what we are planning to do is restore and place teeth in a patient, but we can take different approach. And at the end, the result need to be the same. A patient that I restore for the analog and a mix with digital, using photography, using digital, need to be the same. Different material, but the outcome, the aesthetic outcome need to be the same. In all the cases, or in all the protocols, we need to integrate 4 aspects. Maybe in a few years I conclude that it's 5, but today I think that 4 aspects we need to integrate, and if you miss one of these, probably the case will not be the best. But if you integrate this component, we can guarantee to our patient this prosthesis through the years. Is the smile design, so we need to have a smile for the patient. We don't want to finish with a case that when the patient smiles, you don't see any teeth, or with the incorrect occlusal plane. And you need to integrate this smile with a prosthesis, right? Because when the patient smiles, show the prosthesis. And this prosthesis that is working with the face and the lid of the patient need to be integrated with the biology, with the bone and with the soft tissue. And once we take care of the biological aspect, we finish with the surgery by placing the implant in a specific position according with our plan. Okay, so we start planning the 3D position of our teeth. Basically, in a dentulous patient with terminal dentition, we want to restore, is something new to do. So we can do what is average, where the maxillary incisal curve runs parallel to the lower lip. As you see, parallel is the most popular. But in a ladies, could be touching the lower lip, parallel but touching, or in the man is parallel but not touching. So this is when I need to planning what I'm looking for, one of these cases. So once I design the smile of the patient, I need to fabricate a prosthesis. But once again, this prosthesis, before I place implant, I have a teeth that match with the smile of the patient. The teeth of the canine is okay when speak or with a smile. And this prosthesis internally is related with the bone and soft tissue. So we need to take care, we need to plan it for the biology. We need the space for the prosthesis, for the soft tissue. We need a specific shape for this prosthesis to allow the patient to clean. We can prevent for air escape. We need to prevent for food impactation. We will discuss all these aspects, but we need to take care of the biology. Between the prosthesis that is working with the smile, now need to work with the biology. Let me explain very quickly with 2 simple cases, 2 single restorations. So we need to, at the beginning, create a prosthesis that is according with the smile, especially the lateral, right? When the patient smiles with this lateral, if this is a waxer, looks okay. So this is the restoration. Now I need to integrate this restoration, that is the white aesthetic, with the biology of the patient. Basically, we need to place our implant from the margin of the plant crown around 3 millimeters in apical direction, because this is more or less the thickness of the soft tissue, the area of the biologic width, 3 millimeters. And in cases that, can you see the lateral? This lateral is working with the smile of the patient. When you have the prosthesis, now you need to integrate with the biology, but you don't have this space below the margin. Can you see that the margin is the point of reference? So I need to create or integrate the patient with the prosthesis. And I need to create the space. Now I have the 3 millimeters like the molar. Now it looks the same. So I have the 3 millimeter space. I call the 3A2B rule. Basically is place the implant 3 millimeters in apical direction and keep 2 millimeters of buccal bone to avoid the resorption of this bone and have a compromised aesthetic. You can see in the molar and the lateral, we keep the 2B. Once you have the 3A2B rule, is because you adapted the prosthesis that was adapted to the smile of the patient to the situation with the bone. Now I can place any type of abutment or immediate provisionalization. Anyway, I have the space that I'm planning from the margin of the crown. And in any case, I can obtain what I'm planning. Now the white aesthetic depends on my lab, but I create the pinwheel. I create the space, and the margin is where I plan in the margin. And we need to see what happened at 1 year, 2 years, 5 years, 20 years, of course. But this is single crowns at 8 and 4 years. Take a look, what is the margin? Applying the 3-2 rule. You have the bone at the level of the implant, and this is at 8 and 4 years. Okay, so let's see, use an overview, few slides of the similar concept, but in a full maxilla. This is a complete maxillary rehabilitation, extraction and immediate placement. This is in the paper that I will give the information later, but in this case, when I plan in the case, I need to move the margin of the canine, lateral few teeth a little bit more apically. And you see, take a look at the central. The central are like 1.5 millimeters closer to the area of the socket. But in the lateral, canine and premolar, I am planning to cut the bone. So I cut the bone and create the space according with my planning. After that, I place the implant, but from the margin of each plant crown, I place the implant at 3 millimeters. In the extraction socket area, the implant is at 3 millimeters, but I don't cut the bone because we will lose a little bit the bundle bone. But in the other areas, in few, I need to cut bone until obtain the 3 millimeters. And in other areas, just place the implant at the level of the bone, because when I measure was 3 millimeters. This is when I make the immediate loading, and this is after osseointegration. So what I'm planning is exactly the same of the lateral and the molar. And this is in 2006. And if you take a look of every single year and the X-ray also, you will see that ceramic maybe is not the best, but I work in the manipulation of the soft tissue. So I integrate this prosthesis with the bone and the soft tissue. I can see that after 10, 12 years, in this type of cases, when I make a segmentation, because I place implant for fixed partial denture in central to canine and first premolar to first molar, I can see a small gap. And you see between the two central, but this is after more than 10 years. It's probably because the head is still growing like 2 millimeters every 10 years. So just create a small gap. This is why I like now a splint restoration. But this is 14-year follow-up. In my last live workshop, I present like 12-year follow-up, another case that it was in the paper. You can check in the Facebook, in my Facebook. I have the link from the paper where you can see the cases. Okay, this is at the delivery time, and this is after 14 years. Take a look, where is the bone? More or less similar situation as in the lateral and in the molar. Okay, planning the case. I create the new teeth that stay in harmony with the face and the smile of the patient, transfer the new aesthetic information into the provisional. And what is the point of reference? The margin of the crown. When I place my implant, I know from the tomogram what is the bone. I know that I need to cut in some areas. And this is the way to place my prosthesis after I adapted the bone to the patient. I integrate the biology with this prosthesis that was integrated with the smile of the patient. Day of cementation and 14 years later. I cover the 4 aspects. This is with my patient 14 years ago, and this is in the last follow-up with every month that we have courses. All my patients, they are happy, they feel like a star, so they can come to my institute, and the participant can take a look of the case, and they ask how the patient can clean, and the patient show how clean, and ask all questions, take picture, everything. So depending of the year, people can see more or less years or follow. Okay, what about the 3D digital? This is my passion. I want to do the case. I found some limitation, and now I can do this type of cases totally digitally in a dentulous patient. In patient where I have teeth and implant for full mouth, I can do also, but at the end, I need to do by quadrants or taking an impression. Okay, so just an overview. We need to scan the patient to register in all positions, when the patient speaks, when the patient smiles, in the different type of smile. So I use the face hunter from Circumsan, just to scan the face of the patient. And for a process in our protocol, we have the scan of the complete denture of the patient. Can you see in the top, we section, we divide the prosthesis and keep the palatal that is very well adapted, but replace the old teeth for the new one. Once you create the occlusion and you check digitally the smile of the patient, because you scan the face of the patient. Once you have the teeth, here you can check the apical coronal position. Anterior-posteriorly, if you move the teeth anterior or posteriorly, you will not see in the software. So this is why you need to do at least one trade-in. So this is my trade-in, probably the second one, when the patient now use for a few days, patient agree, and at this point, we don't take any impression, any alveolar impression, any silicone, anything, just scanner. Now we scan the prosthesis also to put in the software. Now, to determine the position of the implant, just make the double scan technique, and you can planning to place your implant. Everything digital, using your guide, you place your implant, and to make the prosthesis, you make the digital impression. Can you see? With the scan bodies. And also using the same prosthesis that was made digital, that the occlusion and everything is okay, I make the immediate loading. Now with this prosthesis, before I screw in the mouth of the patient, I just make this verification device. Okay, and now place the prosthesis of the patient. And in the next day, I have in the yellow one in the bottom is the impression that I made that probably is not 100% precise. I will show you how we solve the problem. The green one is the prosthesis that we made with the scan for models. That is the prosthesis that the patient are using. And in the bottom of this prosthesis, you have the soft tissue before the surgery. And you mix the models in the software, and now you have the perfect soft tissue with the position of the abutments that maybe are not perfect. But in this model, I designed the prosthesis, the bar and the prosthesis. I remove the distal extension and create the shape of the prosthesis. But here is the point. To make sure that I will have a perfect passive fit, I milled the first bar in acrylic. And you have the titan bases, the screws, and this resin that give me like 6 minutes. So what I can do is place a little bit the resin for cementation very quickly, and just put the bar into this verification device that you can do intraorally if you want, because it's the next day. And I hold the prosthesis, screw every screw, and fix. When I screw every titan base is with 100% of passive fit. So I just hold the bar and glue the titan base to the bar. Now I scan this bar, and for the process in the lab, I have the new one with 100% passive fit. And remember that I make the prosthesis before. I glue with the bar, and I deliver the case at the next day, the final prosthesis. Okay, but this have many limitations, and it's not a recommendation doing in the second day, the final prosthesis. This case was an upper complete denture and the lower acrylic and metal prosthesis. This case is more than 2 years, 2 years and a half. And now we are doing the maxilla also. Okay, now let's see what I am planning. This is the main portion of my presentation. By the way, tomorrow, but probably for you it's too late, at 6 p.m. Spanish time, I will do a live workshop and explain this case in detail with all the models, all the protocol, and I will do the case, but in models. So this is the patient coming with this situation with terminal dentition. Take a look of the smile, poor condition. We need to extract all teeth. This is after I clean, and for sure we have bone. I was, as Homa told you, I was working as a surgeon at the beginning of my career, like from 10 years. And my philosophy was extract teeth and place implant where I have the bone. And then take impression and restore some of these cases. Other cases was for my brother, the dentist, or different clinics. And few very nice, the aesthetic outcome, other very complicated to restore. Why? Because when I place implant, I just place the implant at the level of the bone. And maybe that bone is not the ideal for the ideal teeth that we are planning. So we need to start planning the teeth. Start with a different set of models. I will present all this model in the live workshop and start doing the analysis. So what I need to know, where is the position of the teeth? Apical, coronally, anteroposteriorly. This is my point, to see what I can do with the existing situation. So one of the points is extrarally, is this average measurement. And we know that in average, a lip that is 22, more or less, the patient show more or less 2 millimeters. All these numbers are approximation, and I used to start planning the cases. Majority of the time are working. I don't want to say 100%, but more than 99 maybe. Like in this case, patient, the lip is 22 and the existing prosthesis is showing 5.5 maybe. So normally need to show around 2 or a little bit more. So type of smile. Remember, in the ladies, average is touching the lower lip. This is 58%, but the lady could be also not touching, depending on the anatomy, but this is average. So what I can do is, before I make the extraction, I will plan it for the crowns, for the prosthesis, for everything. And I want to show to my patient, say, this is your case, you like it? Yes. I have the margin? Yes. So now go ahead and check the biology. So remember, other point of reference that remains stable is the mucolabial reflection. And you see the mucolabial reflection in the maxilla in average, 22 millimeters in coronal direction, is more or less the incisal edge. So I use this point as reference. At 22 more or less, I put the line where I want the new incisal edge. So the easy way is to develop the smile with the patient. I just take a indelible marker and create the maxillary incisal curve. In the apical coronal position, we need to see anteroposteriorly. Now, you can check how many millimeters you are planning to reduce, like 2 millimeters here, 4 millimeters here. Now I take a model and make the same. Now, what I am planning to do, upper and lower teeth in the laboratory and transfer from the laboratory to the mouth of the patient. So I remove the excess of the teeth, and this will be the maxillary incisal curve. And you see, now I remove the lower teeth because I am planning to extract all teeth and place prosthesis. By the way, many different ways to do the same case. I can do this case for immediate placement and immediate loading, different presentation. This is specific protocol, but of course, any protocol will be okay to obtain the same outcome. So you can see that I extract the lower teeth and prepare for immediate complete denture, and I make the new teeth. How I determine the antero-posterior position? Because I measure from the distal end of the incisive papilla. I you remove the slide because we only have 45 minutes, but was like 15 millimeter. And in average is 12 and a half. So I moved the teeth anteriorly. Ferchis. Okay. Now this is the problem in the quarantine. So we wax up, upper and lower, and I duplicate. Why? Because now I need to fabricate a prosthesis, but I don't want to break my wax up because I will need several models. So I need to duplicate. Okay, so I have the first model from the patient. In this model, I make, in one of the models, the wax up, the new teeth. So I want to prepare a complete denture, maxillary complete denture, to extract the teeth and place the prosthesis, because I need to make sure that patient approve the aesthetic, because we will compromise the lip support. So I explain to my patient, hey, you have terminal dentition. We need to go to a dentulous state and you will evaluate if you like or not. Once you approve, I can move, but I need to make sure where is the margin of this crown to know what I need to do. So I want to do easy for the patient. So I am planning to extract the existing teeth, and in one of the models, listen, all these models are coming from the first one. When I take the first impression, perfect impression, I duplicate many times. So the external wall of this model, all are the same. Okay, so in one of the models, I make the wax up and I duplicate this wax up. All these models are in the articulator, right? So from one of the models, I make a silicone index to copy the margin of the crown, because it's the point of reference to plan the case. And now using the model where I make the extraction, I am checking what is the margin and create the ovate pontic just for the teeth that I will extract. For example, for premolar, we don't have a premolar. I will not create ovate pontic here. Why? If I create ovate pontic, when I extract the teeth and I place a prosthesis with ovate pontic in the premolar, prosthesis not fitting because no space. So I want to make easy. Use ovate pontic in the existing teeth. Once I have this, and you see, I skip for now the ovate pontic for the premolar. From the same model, I put wax, make a occlusal silicone index, and now with a palatal area for support, using the model where I create the ovate pontic, together with acrylic resin, fabricate this prosthesis. So this prosthesis is with the anterior ovate pontic, but no for the premolar. Why? I am looking for the margin. I need to see if this prosthesis in the dentulous area looks okay. If the margin is okay, I can move forward. So upper and lower, I fix this prosthesis with the Fixoden, any dental adhesive, and this is when I deliver the case. Okay. Now, patients are using upper and lower removable prosthesis that she used some dental adhesive, but I can see that the margin is okay. The patient, she's happy with the aesthetic, she can speak, she's very happy. The profile looks okay. So now I have the margin. This is the margin. So now you have the smile of the patient, you have a prosthesis that is integrated with the face of the patient. Now you need to integrate this prosthesis, this one, with the biology of the patient. Now, from the margin of the crown, I need to place my implant 3 millimeters in apical direction, right? And I am planning to place implant in lateral and last molar. But also the prosthesis is central, lateral, canine to premolar. So below the premolar, you need to have the ovate pontic, also below the two centrals. But you already prepare the ovate pontic for the central. When you prepare in the model, you create 1.5 millimeters. Okay, so now I take an impression of this situation with the same prosthesis and create a model. And you see that this model, I have the model, I take the impression with, I make a pickup. I put light silicone in the prosthesis to copy exactly the anatomy, and then an alginate impression, and I do 2 or 3 models with the new existing anatomy, and make a silicone index of the existing prosthesis with the margin. And can you see that we are ready with the margin for the ovipontics of the central lateral canine, but not for the premolar. Now, in this model, I create the ovipontic for the premolar. And you see, you create 1.5 millimeter and adapt it to the margin of the crown that you can see that is okay for the patient. And what the patient are using? The first prosthesis without ovipontics. And here, for the same protocol, I create a new prosthesis with ovipontic. And patients are using the other. For outside, looks the same. Okay, so now I need to see where is every crown in relation with the bone. So I make the double scan technique, and you can see where is the bone, where is the soft tissue, where is the prosthesis, and this is my planning. What is the sinus? I am planning to place tilted implant in the first molar and in the lateral. So take a look here. In this lateral, this is the soft tissue, and this is the margin of my crown. That is okay, I cannot move. So from this margin, I need to place the implant 3 millimeters in apical direction and keep around 2 millimeters of buccal bone. Okay. And in the molar, I need to do the same. From the margin of the molar, 3 millimeters in apical direction and keep 2 millimeters of buccal bone. This is the level of the implant, tilted. Okay. And what about the 2 central? Remember, when we finish, the case is the teeth. This is what the patient wants to see. So what happened with the central? Remember that the margin was okay, and we prepared an ovipontic that was 1.5. So this is the ovipontic is ready, 1.5. And from the margin to the bone, we have 3, because below we will have soft tissue. Now, take a look in the area of the premolar. Can you see the round ball, radiopaque? We are in the middle. This is the soft tissue, and this is the margin of the premolar. Remember, the margin is okay. It's the point of reference. It's my guide. I will not change. So what I need to put below this margin? 1.5 of ovipontic, right? In the final prosthesis. So imagine if you have an ovipontic here that is 1.5. It's touching the bone. And what do you need below this ovipontic? You need a space also for soft tissue. So from the margin of the crown where you are planning to place an ovipontic, you also need from the margin to the crown to the level of the bone 3 millimeters. In this case, probably I need to cut 2.5 millimeters to achieve this 3 millimeters to create the space for the ovipontic. If not, no way to place a prosthesis with ovipontic. I need to overlap, and patient never can clean this area. What about in the other premolar? Take a look. Margin, you can see what is the margin. It's in a correct position. You cannot move apical or coronally because you said at the beginning. So you need 1.5 ovipontic. Take a look. You need to cut more than 1.5 here for the ovipontic, but the ovipontic will be in contact with bone. So you need another 1.5. So you need to cut from margin to the new level 3 millimeters. That probably will be more because bone is into the prosthesis. Okay, for this way, I make the analysis in every single position, and I have at the beginning this prosthesis, the second prosthesis I made in the model, and we order the guide for place the implant. The second one is to make the immediate loading. Day of the surgery, using the sequence, we place the implant in the position that we plan. Okay, now we have all implant in the position according with our plan. Now, and we have the ovipontic for the 2 central canine, but what about for the premolar that are part of the aesthetic? So I screw the abutment angled abutment in the anterior and posterior to compensate because the angulation, and a screw healing cap to avoid that the tissue collapse. So I need to, in the existing prosthesis, important, where you have the perfect margin of the premolar, perforate this prosthesis, and now you can put the prosthesis in the mouth and check where is the margin. Remember what we made? We move the maxillary incisal curve a little bit apically. So we move the margin of the premolar apically. So now if you take a look of the blue line, where is the margin? The bone need to be more or less here. If I want to put a prosthesis with Overjet, but in the other areas it's ready. And you see for the canine, for the central, it's ready. Okay, so I just open a small flap, and all this is what I am doing in the live workshop in Facebook tomorrow at 6 p.m. Spanish time. So I need to cut the bone at 3 millimeters, right? And here is the paper where I have for single crown or for full mouth rehabilitation, how you can make this protocol. So I need to cut. Remember in the tomogram, I just follow the instruction of the margin of the crown, and I cut the bone for palatal to facial. And now I have the space. Basically, below the margin of your full arch prosthesis, you need a band of free space of about 3 millimeters. But if you have extraction socket area, less. Why? Because you will lose the bundle bone, 1.5. But now, in the case of the Overjet, I have the 3 millimeter in both sides. I make the same in the other side. You see? And what happened? Now I can suture, and now I can put the prosthesis with Overjet. Patient can bite a little bit, and I make the immediate loading protocol. With the prosthesis, just fix with the temporary cylinder and Overjet. This Overjet now you can compress. Why? Because you have space. So you design this teeth with the face of the patient and now integrate with the biology, and by placing the implant with primary stability in the perfect position, you integrate with the surgery. So you wait until healing and start the final process of the restoration. Take a look how you manipulate the soft tissue. Now you scan all this model and set the new teeth in which position? In the same of my interim prosthesis. Create the same maxillary incisal curve. And now you can see how you carve in the soft tissue. The shape of your prosthesis will be the shape of your soft tissue, but below the margin of the crown, you need to have a space. If no, no way to manipulate any soft tissue. So take a look at the beautiful contour that you have. And this is the lower for different session. Take a look. Take a look in the premolar area that you create the space. So this prosthesis, you start designing the teeth in relation with the smile. Once you fix and say, okay, this is the prosthesis, this is the margin, you use the margin to integrate the biology with the prosthesis. And once you integrate everything all together, you place your implant, you make the surgery, and now the case is working together. And this is before and after. And you can see with the prosthesis, this is the final, this is a Pretau bridge, made in Italy from my friend Enrico Steger. And take a look, the before and after. So you planning and you show your patient what is the outcome before you place the implant. She knows how it looks before I place the implant. And before and after, with just 4 and 4 implant. So to conclude, before placing any implant, please find, we need to work prosthetically driving. This is the way. You need to place first or determine where is the new teeth in the edentulous area or in the potential area to place implant. And These new teeth need to be related with the face of the patient, with the dynamics of the lip, with the smile of the patient, how the patient speaks, where is the position when smile or when they speak. Once you have the teeth, also to determine the teeth, you can use the stable point of reference that are more or less in harmony always, and you can determine the 3D position of the teeth. And you need to integrate the smile with the prosthesis, with the biology, with the surgery. Need to be all together. If you miss one of these things about that, you will compromise the case for the future. And I recommend to use the 3A to B rule to plan the case, to place the implant, and to restore the implant. Okay, I just want to finish with a picture of my institute in Castellón in the Mediterranean, very beautiful place to live. And during our courses, this is the material that people receive, your full color book with all details, the models that are a copy of the real patient, and during the days of the course, the real patient come to make the follow-up. And for example, this is the case that I present now, and you see, with the guide and the prosthesis. This is what I am doing tomorrow in the live workshop in Facebook. By the way, if you want, you can subscribe to my YouTube channel, because now I start doing, because the quarantine, we don't have anything to do. So I will start adding a lot of summary of videos with a lot of important information. So you can check, but please subscribe to my channel. That is Fernando Rojas-Viscaya in YouTube. And this is the web of my company, Bond Models. We produce all this model, also for my friend Homa. And from my institute, prosthodontic.es. So thank you very much for your attention. And if you have questions, I try to respond. Thank you, Homa.
I can hear that everybody is clapping for you, Fernando. Really outstanding.
I can hear.
Yes. You are a master of planning and execution. It was really fantastic. This is obviously a very, very complex area. If there are any questions, I'm happy to pose them to Fernando. But let's start with the first question is regarding the case that you did where, you did the immediate loading, where you had to reduce some bone and basically replacing just the white aesthetic, just replacing the teeth without any prosthetic tissue. Can you give any guidelines in terms of when you do this kind of restoration, what would you consider would be the longevity of a all zirconia, monolithic zirconia restoration if you're just replacing the teeth without any kind of a pink ceramic compartment? Is there any potential for fracture?
So my experience with this type of prosthesis in full monolithic zirconia is limited to less than 15 cases. And because if it's only white aesthetic, in the area of the interproximal papilla, the connector, anyway, is full monolithic zirconia, is thin. And I don't have any fracture at this point, but we need to make prosthesis a little bit bigger in buccal palatal direction. In buccal palatal. In some cases, the technician add pin ceramic in palatal. Why? Because you can see the frontal view, everything perfect, but in palatal direction, he put a lot of zirconia. And to make nice, he covered with pin ceramic also. But I think depend of the case, if you have flat interproximal areas, no big papillas, we can do thick monolithic zirconia. For me, it's working. My experience is limited to, I have a publication at 7.5 years, 20 arches, but just 2 with, no, sorry, all with pink ceramic. And now I am working in another publication, 35 arches up to 10 years, between 2 to 10 years, and like 2 or 4 of these arches more than this year, and it's working. So it's risky to say. I am doing, and it's working for me, but we need to wait more time to see what happened with the same case at 10 years.
Well, I think
Sorry, probably I'm not very clear about the answer to say, yes, go ahead and make or not. The old report are 7.5 years, the old report, and I'm working in a report of 10 years.
I think you're the first one of the first ones that I know who started working with monolithic zirconia. So you probably have the longest experience working with that. Because many times in those cases that you manage, I find the labs, even though this is just about restoring with the white aesthetic, the lab ends up adding some pink ceramic just to strengthen that. And that creates a lot of negative contour on the intaglio of the restoration.
Of course, yes, this is an advanced topic, the design of the prosthesis, because many technicians want to make a beautiful prosthesis from outside, but who will clean the prosthesis? Yeah. And it's important to think about that because this is our business also. We are working and it's money involved, and the patient pay for us, we pay for the dental implant company, we pay for the lab, we pay for everything. And if at 5 years the prosthesis fracture because patient never can clean in the distal implant because the design of the prosthesis, and now lose the bone, create the cantilever effect, fracture, now what? So very important, the planning of the case to determine if at the very beginning you need to add pink ceramic and you create a beautiful contour, or just white aesthetic. I have in YouTube, if you type my name and oral hygienic, you will see a patient. I make the video because in one of the follow-up with this patient after 3 or 4 years, I check no plaque in any area, double full arch. It's a blind lady, she cannot see for one eye. I say, how do you clean? And she said, with the dental floss. I explain how to clean. And I say, can we make a video and more people can see? She explained how to clean, and I explain in detail. This is very interesting for patients.
So in that case where you only replace the teeth without any kind of a pink ceramic, you design the pontics as scalloped kind of pontics with ovate pontic design. In
yes.
Where you make pink ceramic for the base, do you make that flat, or do you make them also ovate pontic?
I make a convex, all around convex. So it's more or less the same principle. Imagine that you are doing a mandibular or maxillary complete denture that you will convert in a fixed prosthesis with pink prosthetic area. Once you make the conversion prosthesis or you make the pickup, that prosthesis, when you make the pickup, is supported by soft tissue. So that prosthesis is keeping the space that you have at the beginning if you don't make bone reduction. If not, it's another topic, but normally, so once you make the pickup and you cut the flange of the prosthesis and create the convex shape, you never touch what we call the PTJ, the prosthesis tissue junction, that is a small area that could be 1 or 2 millimeters that is flat all around. This area is in contact with the existing soft tissue. So once you make the conversion prosthesis, you screw this prosthesis in immediate loading and you suture the space that you have between the bottom of the prosthesis and the bone is the thickness of the soft tissue. When the patient heals, because the negative pressure inside, when you remove this prosthesis, you can see what? Like the channel with this shape, and the prosthesis is here. But you are not compressing the tissue, because when you make your prosthesis here, bone is here, and you suture below, the tissue is here. But after a few months, the tissue is like this. When you remove the prosthesis, you can see this shape. You are not doing compression. You have 3 millimeters below, and the patient perfectly can clean. This is another topic that I can speak 2 hours about. Design the prosthesis to create perfect transition between a composite or the pink prosthetic area and the soft tissue of the patient, and how the patient can clean. We never remove the prosthesis. Patient with 5, 7, 8, 10 years. When I make the evaluation, if I don't see any plaque, any calculus, tissue very healthy, I don't remove, just X-ray and everything okay.
So what you're describing is that buccolingually, you have the alveolar ridge, which is convex, and your restoration that's also convex, and they are basically just touching in a limited area. But then mesiodistally, you're not trying to create papillae, you're creating great.
Yeah. If it's pink ceramic,
right,
totally flat.
That's right.
Around.
Right, right. Because I see
remember when you make a overdenture using bars.
Right.
Remember when you make a bar and you see the patient at 3 months, what happened with the tissue? Whack, grow and take the shape of the bar. Imagine that you don't have the bar, you have a prosthesis with a nice round shape. What happened in 3 months? The tissue grow a little bit and create the same shape.
Right. So my other question is about the verification jig that you produce digitally. Do you have to section that later and lute them intraorally, or it's not necessary?
Because between the titan base and the verification device that you create, you have like a micro gap. You have a tolerance. And the reason is because I am not sure if doing the intraoral scanner impression, if the accuracy is 100%, probably yes or probably no, but I don't want to take the risk. So I just scan and make a bar, but make the bar with the space for the titan base. So if this is the titan base, imagine that this is the bar. So you have tolerance. When you screw the put the titan base in the bar, and now you put in the top and you screw, every titan base is fitting 100%. And you glue the bar, and now the full bar is fitting, and now you scan again. If you can see that you cannot fit that bar, you need to section, of course, section and glue again. But I never need to section this bar because probably the tolerance, probably it's okay, the bar, probably, but I am doing for this step.
When you check the fit of the bar on the actual prosthesis in the mouth, how do you actually check to make sure it's fit? Because if the bar has some elasticity, can you have some minor misfit, but you can still make it fit by screwing it in place?
In these cases, I make the fit or the evaluation in the verification cast that I show. And when you screw the distal screw, you can see that the bar is totally fitting just with one screw. Remove, screw in the other side, and totally, it's not difficult, it's very simple. Very precise. It's very precise because the verification device is coming from the pickup of the immediate loading. So it's exactly. And of course, the proof is that it's working. In some cases, I am start doing this VIP protocol, but the oldest case is, I think, 2.5 years. The main problem is the fitting. This is for sure is working very well because you control every aspect. And you can do what I make in the verification device, you can do intraorally also, but in specific cases. I told at the beginning that have some limitation. This is for edentulous patient that you don't need to open a flap, you don't need to reduce bone, because in that patient, once I make the immediate loading, next day, I can call the patient next day, remove the prosthesis, and make the same process, but in the mouth.
I see. So your guideline was that in terms of the incisal edge position, for females, you would like to have the teeth come down a little bit more and touch the lower lip, as opposed to male to have some separation. What is the reason for that? And also, do you have any kind of a guideline in terms of the overjet and overbite for male versus female, or do you adjust for every case?
You know, very good question, but I found this in different papers in the literature. And it's a good question. Why is different? Maybe because the anatomy of the man or the lady is more often to see one situation in a man, one in a lady. So I don't know exactly what is the reason. Why is, maybe it's because the anatomy, maybe, I'm not sure why, but I know all this average dimension that more or less, if you analyze, you check with your patient or ladies or yourself, and you will see that more or less is a parameter. This is for some old research, I don't remember now the paper, where they study many cases, people with normal dentition, and determine that this is most popular in lady for one side and the man for the other side.
Do you have any guideline in terms of the overjet and overbite? Some people say they don't like to have too much of an overbite with these type of prostheses. Is there any reason to, or do you want to duplicate what the patient had?
So I try to set the teeth first using all numbers as reference, and then try to create an occlusion that is protected, canine guidance. So according with the movements, I make that the case is working. So you want to create the specific area where the patient can have a correct guidance for desocclusion. But no, I don't give any specific number. It's during the process, when you are doing, you will see. Because as in the maxilla, I told you that the lip is 22, from the mucolabial reflection is 22. In the lower, for example, in this case, also from the mucolabial reflection to the incisal edge in average is 18. So when you have everything in the articulator, you are planning from inside to outside. And for example, in the lower, when you use the 18 millimeter from mucolabial reflection to the incisal edge, now you put a line to the lower tier of the retromolar pad, and this is the occlusal plane. So when you are working and doing the wax up, you finish with the teeth. And I don't measure exactly how many millimeters, more or less. When you make the movement, you create the position. And when you finish, you have this distance, but I don't check exactly this overjet or this overbite.
Well, Fernando, we can go on a long time because you have so much experience with this, and we can talk about this for a long time, but I appreciate you. I know that it's very late at night right now in Spain, and you're very generous with your time, and I appreciate all of that. So anybody who would like to get more from Fernando, you can join his Facebook page tomorrow. He's doing a live webinar on Facebook, and you can participate with him and learn from him.
So, I am taking pictures.
Yeah.
Yeah, tomorrow will be my last workshop. This was because we don't have anything to do, so I said in my home cameras, light, everything. And I find that it's very interesting. And I can explain as a support of what I present today, tomorrow, but with the models, and they can see how we manage the case.
Yeah, that's great. So, and thank you for sharing that. So I really appreciate, hopefully everything will open up and we get to travel. The best place to take a course is Fernando's Mediterranean Prosthodontic Institute. It's really, he's very warm and hospitable. He has a lot of social activities set up for you with flamenco dancers and paella and great food and all the tapas that they have. And it's a really great place. He and his wife, Noelia, are a great host for the Institute. And they always treat the participants, not only educationally, but socially very well. So hopefully some of our participants who joined from all over the world will come and visit you and when everything opens up. But in the meantime, stay safe, be well.
Okay, my friend, be here. I love you so much and see you next time. Thank you.
Love you too, my friend. All right.
Bye.